Now in this particular study, they looked at using the BPI, or the brief pain inventory. So there was quite a number of patients in this study, and it was actually a side study for a cancer study. The vast majority of patients actually had active disease, and most of the patients were pretty reasonable in terms of their performance status, with over 60% having an ECOG of 0 to 1. So they used the BPI to assess current pains along with their worst, their average, and their least pains over the last week. And overall, patients rated their current pain as less severe than their worst or average pain over the last week. The worst pain over the last week contributed most to ratings of pain interference, that is, interference with things that they needed to do. It may include sleeping or just activities. When they analysed this, the findings indicated that the ratings of recalled worst pain rather than ratings of current pain might better reflect the overall experience of pain. And so what that was basically saying is that patients, when you ask them how their pain is at present, actually tend to underestimate the pain that they've got. And the other suggestion from their study was that there may be a guide for the choice of recall period for clinical cancer trials with pain as a self-reported outcome, in that it is difficult for patients to remember what their worst and best pains were over a period of a week. And BPI can be done over a period of 24 hours. Another one that can be used is the memorial pain assessment. So there are 3 visual analog scales, one of pain intensity, one of pain relief, one of mood, and then there's a jumbled categorical scale out of 8. So here at the top you can see the pain scale from least to worst, the jumbled words that the patient would pick out, whether their pain is no pain or excruciating pain or just noticeable, and thirdly how much relief they're getting, and then their mood as well. The BPI, the shortened version of the BPI, is over a 24-hour period. So this looks at the worst pain that they've had over the last 24 hours, when their pain's been at its best, and how they would average it out over the last 24 hours, and how their pain is right at this minute. And from that study that I mentioned previously, the problem for patients is that they tend to underestimate their pain. And just to mention the McGill Pain Questionnaire, the McGill questionnaire is quite complex and complicated, and really is not an option when you're looking after patients in the clinic. It's really a research tool. Now, the other important thing to remember is pain threshold. And although we're giving analgesics for pain, pain relief and analgesia are not the same. The problem is because pain is more than just physical pain, as I've alluded to in previous slides. It's a somato-psychic experience, and there may be a wide scope for the use of other interventions. So one might need to look at other significant factors, such as depression. We know that depression is a common problem in patients with advanced malignancy. But there are also other factors, particularly anxiety. So things that may help raise one's pain threshold, certainly getting relief of other symptoms such as nausea or vomiting, or perhaps improving someone's appetite, to make sure that someone gets a good night's sleep, or at least they sleep for a few hours rather than having disturbed sleep throughout the night. Just to make sure that there is some understanding of the patient's situation, and that they do have empathy from not only their family but also the medical team looking after them. And so things may be used to help the patient. Relaxation therapy may be quite beneficial for the patient, and anything that will help reduce the anxiety and elevate their mood. Now, this may be some type of behavioural therapy. It may be some medication that's useful.